Oregon's law is called the Death with Dignity Act. In 1994, the Citizens Initiative passed by a slim margin of 51 to 49%, and legal challenges delayed it from taking effect until the fall of 1997. Under the act, the Oregon Health Authority is required to gather information about patients and doctors who participate and publish an annual report. Well, now we're getting a look at the latest data from 2024. It includes this graph that charts the number of prescriptions written for lethal amounts of medication and the number of people who died by choosing to take them. OHA began collecting data back in 1998, and you can see a pretty clear trend of the number of prescriptions outpacing the number of deaths throughout the Act's history. Now, looking at the last 5 years, we see a dramatic spike in both prescriptions and deaths between 2022 and 2023. According to OHA data, prescriptions increased around 30% in 2023 compared to 2022, and deaths increased roughly 20%. OHA attributed this spike to an amendment to the law in 2023 that removed a requirement that patients live in Oregon to use the program. Their data shows that out of 2,481 deaths between 1998 and 2022, 3 were out-of-state patients. Now compare that to 2023, where out of 386 deaths, 25 were out-of-state patients. And in 2024, 22 out of 376 deaths were out-of-state patients. Okay, I know a lot of numbers there, but the fact that more of these prescriptions are going out and not being used caught our attention. OHA says that in context with the rest of the data over the last 20 plus years, it's in line with the general trend, as it's happened 3 other times since 2000. As far as the reason why OHA thinks more prescriptions are being written, the agency points to media coverage and awareness that medical aid in dying is an option.
I think what we see in this data is that the law is working as intended. A very small number of people will request this medication every year. A smaller number, in fact, will take it, to the point where it is only 0.9% of all deaths in Oregon were from ingesting Death with Dignity Act medication. What we see as well is the discrepancy in the number of people who request the medication but never take it. That is, again, the law functioning as intended.
All right, that's Callie Riley, the regional director for the national nonprofit called Compassion and Choices. They advocate for expanding options for end-of-life care, including working to get Oregon's Death with Dignity Act passed in the first place. They're also helping push for similar legislation in states like Delaware, Illinois, and Montana. And while they don't work directly with patients anymore, they do provide resources for anyone considering their end-of-life care options. So we asked her to elaborate on the difference between the number of prescriptions written and deaths.
We don't think any one person should, request a prescription, should ingest it simply because they've requested it. We think that the patient should be able to decide for themselves. And so we know in many cases is that simply having the peace of mind that this is an option or having the medication available without ingesting it can itself relieve a terminally ill patient's suffering. It is itself palliative.
However, for some, like the pro-life organization Oregon Right to Life, that discrepancy in data is cause for concern. Here's the executive director of that group, Lois Anderson.
The reason why we are so concerned about that is, first of all, it reveals that the idea that that physicians, the medical community can consistently and accurately diagnose whether or not you have fewer months to live. It has always been it's not true. From the beginning, the medical doctors have told us that's just not a thing. We can guess, we can predict in some ways, but there really isn't a consistent, for sure way to know how long somebody is going to live with a diagnosis. The second thing is that means that there are doses of drugs laying around in somebody's house that can kill someone.
Here's how the Death with Dignity process works now. Patients must be 18 years old or older, capable of making and communicating their own healthcare decisions, and diagnosed with a terminal condition that will lead to death within 6 months. It's up to the doctor the patient is working with to decide whether all 3 of those criteria are met. If so, the patient then has to make 2 separate verbal requests to the doctor, at least 15 days apart. They must provide a written request to the doctor signed by 2 witnesses, with at least one who isn't related to the patient. The primary doctor working with the patient has to confirm their diagnosis and prognosis with a consulting doctor. Both doctors have to confirm that the patient can make healthcare decisions for themselves. After the 15-day waiting period is over, the written request has been submitted and they have consulted another doctor. The primary doctor must wait an additional 48 hours before writing the prescription. The primary doctor also has to inform the patient of any feasible alternatives to taking the prescription, things like hospice care and pain control. Now, the patient can rescind their request at any time during the process, and the doctor will offer an opportunity to do so at the end of the waiting period. Now, there are a few exceptions to the current waiting period of 15 days for people who are given less than that much time to live. But as far as the standard process goes, doctors are required to report every step to OHA, as well as follow up to inform OHA about how the patient died. But a new bill in Salem could change that process. Most notably, Senate Bill 1003 would reduce the waiting period after a patient asks for the medication from 15 days to 7. It would also make a slight adjustment to the consulting doctor requirement. Now, last month during public testimony, more than 150 people spoke out against the bill, with only a handful in favor.
Even some physicians themselves are really not trained to make a 6-month diagnosis in the first place. They're not specialists in that area. And it really isn't just a random thing that we're talking about giving somebody a prescription for medication that will kill them if they take it. This is, so it's a very serious diagnosis. It's a very serious prescription and decision by the patient as well as the medical provider.
But there are aspects of the bill that supporters say close key gaps in end-of-life care for patients.
The good about Senate Bill 1003 is that it requires hospices and healthcare facilities to disclose their policies around medical aid in dying to patients. We think that transparency helps consumers make an informed decision about where to get hospice services, where to seek healthcare services, making sure that your hospice or your healthcare facility is going to offer the kinds of care that align with your values, priorities, and beliefs. Reducing the waiting period is really important. In the newly amended version of the bill, that is down to 7 days from 15. And then creating an electronic filing system for records really kind of modernizes the reporting infrastructure for the Death with Dignity Act. Having to deal with paper forms, faxed forms can be a little bit cumbersome. And so we think that in as much as the state is doing that kind of reporting, that it is going to improve it.
Well, right now, the bill is being evaluated by the Senate Rules Committee, and we'll keep tabs on it in the weeks to come. So, talk to us. What do you think about the Death with Dignity Act? Is it something that you think is a good option for people to have if they have a terminal illness? Tell us why or why not. Email us at thestory@kgw.com or call and leave a voicemail, 503-226-5090.